Hello everyone and welcome back to my channel. This is Professor Asif Qureshi and you are watching Dr Asif Lectures. हम 10 teachers से gynecology कर रहे हैं and chapter number 5 is today's video's topic, and this chapter deals with implantation, obviously implantation of zygote and early pregnancy. So let's start the chapter with the learning objectives. The learning objectives of this chapter will be to understand the social and emotional context of early pregnancy loss. This is very important. इस chapter में we'll be talking about early phases में what happens, right? So after fertilization, the zygote which is produced travels in the fallopian tube and it reaches up to the uterus, and in the uterus it gets embedded. तो ये जो early days हैं इसमें sometimes things go wrong, and we will study about miscarriage. So miscarriage is the pregnancy loss, and this is something very, very devastating. Obviously, if somebody knows that she is pregnant, फिर सारे ज़ाहिर expectation, and if the baby is lost, particularly in the early, and this is actually very common. Miscarriage अभी हम पढ़ेंगे तो आपको बताऊंगा कि this is actually very common and prevalent condition, and it obviously has a lot of social and emotional stuff associated with it. So we need to understand why high suspicion of pregnancy is needed in all women of reproductive age with symptoms. High suspicion of pregnancy with symptoms means if you have missed cycles. So if the date is missed and the female is sexually active and in the reproductive age, you have to consider pregnancy. Obtain a detailed knowledge of clinical presentation and management of the miscarriage and ectopic pregnancy. We'll talk about miscarriage पे हल्का सा तो मैंने आपको बताया कि is the loss of the baby in the very early days of pregnancy, and ectopic pregnancy is usually the implantation is in the uterus if it happens other than uterus at an abnormal place such as in the fallopian tube or in the abdominal cavity somewhere or anywhere else in the pelvis other than the uterus, then it is called ectopic pregnancy. It comes with a lot of complications. We also need to understand and obtain awareness of less common early pregnancy conditions, including recurrent miscarriages, gestational trophoblastic disease, and hyperemesis gravidarum, which means a lot of vomiting. So recurrent miscarriages means that a couple is trying to conceive and the female is experiencing again and again miscarriage. So ये learning objectives हैं हमारे chapter के. They roam around early pregnancy stuff, loss such as miscarriages and ectopic pregnancy and early pregnancy symptoms. So let's talk about implantation and establishment of pregnancy. So once zygote is produced, उसके बाद के जो steps हैं जिसमें zygote implant होता है in the uterus for the next 9 months, उस पर बात करते हैं. So after ovulation, the cells of the dominant follicle, Graafian follicle की बात कर रही है, forms the corpus luteum, and the corpus luteum produces a large amount of progesterone, which prepares the endometrium to support the pregnancy. So ये हमने पिछले चैप्टर में पढ़ा भी है कि with the normal, with every normal menstrual cycle, what happens कि if this is the ovary और इससे एक ovum release हुआ है, so the ovum gets into the fallopian tube, वो अपनी journey start करता है, and if sperm enters, if fertilization happens, if intercourse happens, and sperm and ovulation timing matches with the release of ovum, so वो sperm यहाँ travel करके in the fallopian tube और यहाँ fertilization हो जाएगी. So if this happens, then zygote continues to go down and fixes itself into the uterus. This is what we call implantation. ये तो तब होगा जब fertilization का process होगा, लेकिन हर menstrual cycle पर तो जाहिर है fertilization नहीं हो रही होती, right? So जो ovum निकलता है, पीछे जो structure बचता है, that is called corpus luteum, and the job of the corpus luteum is to produce progesterone, and this ovum then continues the journey, obviously in the absence of sperm, but the progesterone with every menstrual cycle prepares the uterus as if there was a pregnancy going to happen. तो यानी ये है कि ये एहतियातन कॉर्पस ल्यूटियम हर मेंस्ट्रुअल साइकिल में बनता है कि अगर फर्टिलाइजेशन हो, क्योंकि जाहिर है जब ओवम रिलीज हो रहा है तो इसको तो ये नहीं मालूम ना कि फर्टिलाइजेशन होनी है कि नहीं होनी. सो नेचर का सिस्टम ये है कि एवरी मेंस्ट्रुअल साइकिल पे कॉर्पस ल्यूटियम प्रोजेस्टेरोन रिलीज करेगा एंड इट प्रिपेयर्स द यूट्रस. व्हेन वी से प्रिपेयर्स द यूट्रस, इट मींस इसकी ब्लड सप्लाई बढ़ जाती है एंड glycogen enrichment and all these things, so that if pregnancy happens, the uterus is prepared to host the zygote. So that is the sort of story. This happens with every menstrual cycle. If fertilization happened, this is all good. Progesterone did its job. If fertilization doesn't happen, ovum goes away with the menses. So successful implantation occur when oocyte is fertilized in the fallopian tube and implants in the endometrium of the uterus around 7 days after ovulation. So diagrammatically, if you look here, this is the fimbriae. Somewhere here would be the ovary releasing the ovum. If fertilization happens with the sperm, then the zygote moves on in the fallopian tube, and while it is moving on, एक cell से दो cell, दो से चार, चार से आठ cell divide हो रहे हैं, and you see by day 7 to 10 the zygote has traveled all the way down into the uterus. बहुत सारे cells बन चुके हैं, infect cavity बन चुकी है, gastrulation का process somehow start होने लगा है, and now it is fixing into the uterus. So this fixing into the uterus is known as implantation, and the zygote will stay, the fetus will now stay here for the next 9 months. Okay, और यहीं पे सारी development होगी. So that is an important diagram to understand. The implanted blastocyst secrete human chorionic gonadotropin. Exponential increase in the HCG act on the corpus luteum to rescue it from the luteolysis and to maintain the progesterone. It's a beautiful concept. देखें, जब ये ग्राफिन फॉलिकल है, इससे ओवम रिलीज हुआ तो पीछे जो स्ट्रक्चर बचता है उसको हम कहते हैं कॉर्पस ल्यूटम. कॉर्पस ल्यूटम से क्या प्रोड्यूस होता है? इट प्रोड्यूसेस प्रोजेस्ट्रॉन, एंड प्रोजेस्ट्रॉन प्रिपेयर्स द यूट्रस फॉर प्रेगनेंसी. राइट, अब फर्टिलाइजेशन हो गई है, जाइगोट बन गया है, सो द यूट्रस नीड्स टू बी प्रिपेयर्ड ऑल द टाइम. सो this progesterone is required all the time throughout the pregnancy, and this corpus luteum is obviously required at least in the early phases. Later phases में फिर placenta से भी release होता है और यहाँ से भी release. So but early stages में we need to keep the corpus luteum. And how do we keep the corpus luteum? ये जो यहाँ पे structure fix हुआ है, implant हुआ है, यहाँ human chorionic gonadotropin बनना शुरू होता है. It keeps the corpus luteum, which keeps on secreting progesterone so that the uterus is maintained. It's a beautiful concept. The corpus luteum support the pregnancy up till 8 weeks. इसके बाद placenta takes over, फिर placenta develop होना शुरू होता है और फिर progesterone की production placenta से start हो जाती है instead of corpus luteum. Okay. Human chorionic gonadotropin can be detected in the urine samples, and it is very sensitive for pregnancy. Actually यही pregnancy test है, वो कहते हैं ना pregnancy test करवाया, so we actually check for beta HCG, और अगर ये है urine में तो the person is declared pregnant, right? And इसकी origin अब आपको पता है कि HCG कहाँ से आया, यहाँ से आया, right? When the blastocyst is getting implanted in the uterus. A transvaginal ultrasound can detect an early intrauterine gestational sac, the first sign of a normal pregnancy around 5 weeks of gestation. A few days later, yolk sac can be seen. So beta HCG, the most earliest thing which a female notices will be a missed period. So a missed period, menstrual cycle was expected, but it is not there, and then obviously they know that they have been trying for pregnancy. So their attempts of pregnancy, sexual intercourse, their timing, and missed period. This is what brings the person to the clinic, and then obviously you to अभी तो आजकल तो बहुत सारी strips भी होती हैं, so early strip test भी कर लेते हैं लोग घर पे ही, urine test करते हैं, that also checks for HCG, but then you do laboratory HCG levels as well. तो फिर इससे भी पता चल जाता है कि pregnancy है, तो it confirms, and then obviously transvaginal ultrasound is a key thing to be done. Okay, so gestational age is calculated from the last menstrual period. Okay, this is important. ये मैंने history taking में आपको chapter 2 में समझाया भी था, right? In the early stages of normal developing intrauterine pregnancy, serum concentration of HCG will normally double every 48 hours. So this is what you check to confirm if it is pregnancy or not. A normal pregnancy with serum HCG concentration of more than 1500 international units per liter should be confirmed as intrauterine on a transvaginal ultrasound. So many people do not do transvaginal ultrasound to confirm pregnancy. They do it anyway during 6 weeks to see the fetal viability. But anyways, the first test to do to confirm pregnancy would be beta HCG. Okay. Now, the first term, miscarriage, it's a pregnancy that ends approximately before 20 weeks of gestation. So that is the technical definition of miscarriage. Okay. Clinical presentation, the most common sign is vaginal bleeding. Imagine if the baby is being lost, it will be vaginal bleed. And this is what brings the person to the clinic, that they know they were pregnant and now heavy vaginal bleed. Miscarriage is common. I would actually use the word very common. It's very common. 10 to 20% clinical pregnancies प्रेगनेंसीज में मिसकैरेज होता है, with the risk increasing with the maternal age. More the age, more the chances of miscarriage. Clinically, miscarriages can be classified into different types based on clinical presentation and investigation findings. अभी हम देखते हैं कौन कौन से miscarriages हो सकते हैं. So for example, there is a category called threatened miscarriage, and ultrasound पे you find intrauterine pregnancy, but obviously with remnants because it has been miscarried, and clinical presentation is by vaginal bleed, and you see cervical os is closed. On speculum examination you just do supportive treatment, यानी अगर पेन है तो पेन किलर, अगर वॉल्यूम लॉस ज़्यादा हुआ है तो वॉल्यूम रिप्लेसमेंट. This is threatened miscarriage. Then there is a category called inevitable miscarriage. There is fetal heart sounds हम बात कर रहे हैं, FH अगर लिखा हुआ है, so this is fetal heartbeat, right? So fetal heartbeat present, fetal heartbeat absent, that's what it is. Intrauterine pregnancy, vaginal bleed, and expectant medical or surgical. If you, अभी हम इनके बारे में पढ़ भी लेते हैं सारी ये चीज़ें कि which one is what, but anyways, the miscarriage is a bad news for the patient anyways. Incomplete miscarriage, there will be retained products within the uterine cavity. There will be vaginal bleed as the presentation, and you have to remove the remaining stuff which is in there by DNC, for example. Complete miscarriage is empty uterus, everything is gone, pain and bleed, you do supportive treatment, do nothing, right? Missed miscarriage, it happened, pata bhi nahi chala, and then suddenly kisi later follow-up pe, kisi ultrasound pe pata laga there is no pregnancy anymore, and then you do medical or surgical depending upon if any products are still retained in the uterus or not. Okay, तो ये डिफरेंट फॉर्म्स हैं. अब ये फॉर्म्स क्या हैं, बस इसको डिफरेंट नाम दिए हुए हैं. मिसकैरेज इज़ द लॉस बिफोर 24 वीक्स. Etiologic factors, this by far is the most common reason, chromosomal abnormalities, and these are minute genetic alterations which actually lead to miscarriages. It's not uncommon. Endocrine disorders, mother may obviously, uterine abnormalities, infections, and certain drugs. How would you investigate it? It is fundamentally important to assess the women who is miscarrying clinically. You do the abdominopelvic examination in conjunction with the results of the investigation. अभी देखते हैं कौन कौन सी investigation. Usually you do the transvaginal ultrasound or transabdominal ultrasound to see के cavity है नहीं है, uterine cavity में products हैं नहीं हैं, what is the condition there. You actually need to see that, and you also do hemoglobin and group and safe type of cross match, so that if bleeding is heavy and if you need to transfuse the person with the blood, you need to know what was the blood group, right? Major to assess the degree of vaginal loss and rest of the status. So most of the time you have to resuscitate the patient, particularly with providing a matched blood group. How do you manage them? Can be managed by medical or surgical or just reassurance, depending upon how they present. If they have presented with severe bleeding and their blood pressure is dropping, for example, so you will identify those patients during the ABC examination, the airway, breathing, and circulation. Maybe you need to infuse fluid and maybe blood. Expected management allows for avoidance of surgery after a spontaneous miscarriage where pain and bleeding resolve. Repeat ultrasound scan is not required to confirm the completion. Women may be advised to take urinary pregnancy test after 3 weeks. This will confirm. If the test is negative, it is miscarriage. Pregnancy is gone. Women undergoing expectant management may require unplanned surgery, क्योंकि surgery obviously, even DNC भी, it's an invasive procedure ना, उसकी अपनी complications होती हैं. So you try to avoid that as much as you can. But again, clinical practice में decisions are based on the context. तो आपको देखना पड़ेगा scenario क्या है, right? Medical management is increasingly used in an outpatient setting to allow women to miscarry at home. It involves the administration of single or repeated vaginal or sublingual dose of prostaglandins E analog, which is misoprostol. Some centers use pretreatment with progesterone antagonist, mifepristone. The side effects include pain, vomiting, diarrhea, because these drugs then increase the uterine contractility so that any retained products of miscarriage are also removed out. As with the expectant management, there is no need of routine scan or follow-up. Just after a few weeks, repeat the pregnancy test on the strip. If it is negative, all good. But if it is positive, it means that maybe there are some retained products of the fetus which actually has been miscarried, but there are some cells there. Maybe it requires some surgical intervention later. Okay. Ultimately, sometimes you do need surgical management of these patients if there is persistent and excessive bleed which is not being controlled and the person is getting hemodynamically unstable. It can be done by manual vacuum aspiration under local anesthesia. Sometimes you may need general anesthesia to do a deeper extraction. Vaginal or sublingual misoprostol is frequently given because it helps getting the retained products out of the uterus. However, surgical evacuation has its drawbacks. Obviously, it's a surgical procedure, so it can, perforation ho sakta hai genitals ka, and all sort of post-operative complication such as infection, trauma to cervix, cervical incompetence. इसीलिए हम सर्जरी को इस तरह के पेशेंट्स में लास्ट रिजॉर्ट तक अवॉइड करते हैं, so that you try not to disturb the patients if you can deal with them on medical management. Counseling is very, very important. This is superstar part of the management of a patient with miscarriage, because miscarriage can be distressing. A mother losing the baby, a family losing the baby. This is something of great psychological impact, and this has to be taken care of. So counseling बहुत ज़रूरी है. बाज़ औक़ात बाज़ health care centers में trained counselors होते हैं, and this is very much required at times, right? Recurrent miscarriage, what is this scenario? This is, as the name indicate, that the miscarriage is happening again and again. Recurrent miscarriage is defined as the loss of 3 or more consecutive pregnancies, and it affects about 1% of the couples. Risk factors of recurrent miscarriages include both advanced maternal and paternal age, also father, obesity, chromosomal translocations, this is very common and important, uterine structural abnormalities, anti-phospholipid syndrome. देखें ये आपको लाजमी याद होनी चाहिए सारे नाम, because they are all important and common causes of recurrent miscarriages. Okay, investigation of recurrent miscarriage should involve testing of anti-phospholipids. So this should be part of your workup doing if you are investigating somebody with repeated. Also karyotyping. I would also like to throw this concept. You should do karyotype because chromosomal abnormality is important cause of recurrent miscarriage. Aspirin and low-dose heparin can reduce miscarriage rate in some women. Balanced translocations may be overcome by pre-implantation genetic diagnosis or gamete donation. So directly gamete you donate, sometimes zygote implantation directly. Although treatment with progesterone and corticosteroid or metformin has been advocated to take care of the insulin resistance and obesity. So these are all the important considerations. I think ये बड़े beautiful तरीके से 10 टीचर्स ने समराइज किया है recurrent miscarriage में कौन सी investigations करनी चाहिए और कैसे manage करना चाहिए. Now the concept of ectopic pregnancy. This is defined as implantation of pregnancy, which means implantation of the zygote or blastocyst outside the normal uterine cavity. So 98% happens in the fallopian tube. Rarely it can be implanted in the interstitium of the tube, ovary, cervix. Actually, it can go anywhere. Any pregnancy other than uterus is ectopic. The most common location is the fallopian tube, and it comes with complications. Okay. 1 in 80 pregnancies are ectopic. They account for 9 to 13% of maternal death. So this is, I mean, खुद imagine करें ना, ये fallopian tube है, इसमें पूरा zygote और फिर पूरा baby develop हो रहा है. So at some point it may rupture, it may bleed, so there are complications. Okay, so these females die pretty commonly. The incidence of heterotropic pregnancy in the general population is lower, but significantly higher with IVF. When you are doing in vitro fertilization and then implanting, there are chances that you do this wrong. Etiological factors of ectopic pregnancy: fallopian tube, particularly after pelvic infection. If there is fibrosis due to previous surgery, this is very common because imagine this is a normal route, right? This is the ovary, this is the fallopian tube, and this is the uterus. So the zygote has to travel all the way down here and then come here in the uterus to get implanted. लेकिन अगर previous surgeries हुई हैं, कोई fibrosis है, fibrous band है, strictures है infection की वजह से, so the route and the normal pathway for zygote is disturbed, and then zygote sometimes gets stuck and get implanted in the the fallopian tube. So this is very common. So all or any pelvic conditions, inflammatory particularly, or previous surgery can lead to ectopic pregnancy. Even appendix operation previously, previous cesarean section, पहले को बच्चा हुआ C-section से, IVF का use, contraceptive devices का use, endometriosis, these can all lead to ectopic pregnancies. Okay. The majority of the patient with ectopic pregnancy basically present with subacute clinical picture of abdominal pain. This is the most common presenting feature, and also vaginal bleeding. Rarely these patients present very acutely with rupture. So this can also happen, right? Okay, fallopian tube mein baby is growing and then it ruptures. So that is something very serious. And the free blood in the peritoneal cavity because of the rupture can cause diaphragmatic irritation and shoulder tip pain. So that is a very nice clinical scenario for the examiners to test you. Okay, can you correlate shoulder tip pain with the rupture? So if there is rupture of the fallopian tube, there is blood under diaphragm, irritation of the diaphragm, and then the nerve supply, referred nerve supply. Okay. It is, however, important to be aware that it is common for women to experience bleeding and abdominal pain with a viable intrauterine pregnancy as well. So anyone coming to you with bleed and abdominal pain does not always mean कि उसको ectopic pregnancy ही होगी. हो सकती है. You investigate and you confirm, right? What investigations you need to do? You have to do obviously ABC तो करना ही है ना हमेशा. Abdominopelvic examination भी हमेशा ही करना है. But in terms of investigation, do the transvaginal ultrasound, because this will tell you where the fetus is growing. Identification of an intrauterine pregnancy on transvaginal ultrasound effectively exclude the possibility of ectopic. So this is very, very good tool, highly sensitive. A transvaginal ultrasound shows an empty uterus with an adnexal mass. Adnexal mass यानी ovary और fallopian tube वाले area में अगर कोई mass develop हो रहा है, it is again also very sensitive and specific. Okay, so ultrasound is the answer if you need to look for where the pregnancy is growing. Then you do the serum HCG levels. It almost doubles every 48 hours. यानी हर 48 hours में HCG के levels double होते हैं, right? This is when we are talking about normal pregnancy. Okay, normal intrauterine pregnancy. In patients with ectopic pregnancy, the rise of HCG is suboptimal. It's not that value. Okay, so this also gives you an idea if the pregnancy is proceeding intrauterine or if it's proceeding in an ectopic manner. Hemoglobin and group and save always do that, because if this is ectopic, it can rupture, there can be severe bleed, and you may need to transfuse the patient. So always do that. In up to 40% of women with ectopic pregnancy, diagnosis is not made on the first attendance and they are labeled as having a pregnancy of unknown location. Obviously, later on when you do the transvaginal ultrasound, you do the HCG levels, then you label. And these are high-risk pregnancies, okay? You need to be very careful for these particular patients because they are high-risk patients. And how do you manage these patients? You can do expectant, just see and watch and observe. You can do medical intervention or surgical intervention, depending upon what is the situation. So expectant management, for example, is based on the assumption that significant portion of all the ectopic pregnancies will resolve actually without needing any treatment. So you monitor these patients very carefully. Although medical management, methotrexate is a treatment for the patients with minimal symptoms and an adnexal mass of less than 40 millimeter in diameter and a current serum HCG concentration under 3000. Methotrexate, you know what it is. It's a folic acid antagonist, so it inhibits the DNA synthesis, particularly affecting trophoblastic cells. And the dose of methotrexate is calculated based on obviously the patient's body surface area and weight. After methotrexate treatment, serum HCG is usually routinely measured in days per 4, 7 and 11. Then weekly medical treatment should therefore only be offered if facilities are present for regular follow-up. ये ना हो कि आपने methotrexate दे दिया, the cells are dying and the patient goes into crisis, and then you do not have any facility to deal with that. Medical treatment should therefore only be offered if facilities are present, right? The few contraindications to medical treatment, however, are the chronic liver disease, because methotrexate should not be given in chronic liver, renal or hematological problems. If there is any active infection or immunodeficiency, that is problematic. Breastfeeding, you don't give methotrexate. There are also known side effects of stomatitis. These are the side effects associated with methotrexate itself. It is important to advise the women to avoid sexual intercourse during the treatment and to avoid conceiving for at least 3 months after methotrexate treatment. Okay, because because this is teratogenic, if there is another pregnancy happening, that will be problem. Okay, surgically, what would you do? The standard surgical treatment approach is laparoscopy. Laparotomy, that's a bigger and very invasive procedure. It is kept for those patients where you decide that laparoscopy is not going to work. The operation of choice is removal of the fallopian tube and ectopic pregnancy. So basically you are trying to get rid of the ectopic pregnancy, right? In most of the cases it is already dead and you need to remove it. If it's not, you are doing it by using methotrexate. The operation of choice is removal of the ये बात हमने कर ली. In some cases, a small opening can be made over the side of the ectopic pregnancy and it's extracted. This is called salpingostomy. But the point is that you have to see what is going to happen. Expected management include just see, wait and watch. Maybe the pregnancy is proceeding fine, and some pregnancies do lead to good and favorable outcome even if they are ectopic. But sometimes the baby dies in utero and it resolves itself. You just monitor the HCG level. So depending upon the patient scenario, but sometimes you intervene with methotrexate to kill the developing fetus and then get rid of it. Sometimes you do it surgically. Anti-D administration, rhesus isoimmunization, can occur after early pregnancy problems, and there are some circumstances where women are rhesus negative. They require anti-D prophylaxis. This is very common. All rhesus negative women, listen to this carefully, who have surgical procedure to manage ectopic pregnancy or miscarriage should be offered anti-D immunoglobulin, और एक particular dose है उसका, within 72 hours of the surgery. This is important. ये rhesus हम सिर्फ erythroblastosis fetalis के वक्त पे नहीं कर रहे होते. Even if you are dealing with ectopic pregnancies and miscarriages, you give anti-D, right? A Claheur test is not needed to quantify the fetal maternal hemorrhage. It's not required. Anti-D is not required for threatened, incomplete, or complete natural miscarriages. If it's natural, things have gone, you have not intervened, you don't need that. This is required particularly when you're doing a surgical procedure, you are intervening to the ectopic pregnancy. Anti-D may not be required after medical management as well. So bottom line, anti-D administration by and large is required if you are doing a surgical procedure for ectopic pregnancy. That's by and large the general formula. Summary of the early pregnancy disorders. ये कुछ important चीजें जो table में दी हैं before we end the chapter. Particularly hyperemesis gravidarum पहले कर लेते हैं. इसमें होता ये है कि patient ज़रूरत से ज़्यादा vomiting की complaint करता है. Hyperemesis मतलब बहुत ज़्यादा उल्टी कर रहा है. Risk factor का मतलब ये है कि multiple pregnancies, so maybe there are twins or triplets or quadruplets, या फिर there is gestational trophoblastic disease, इसका हम जिक्र भी करेंगे आगे. Excessive nausea and vomiting is the presenting complaint, and antiemetics आप देते हैं, and you may sometime need fluid and electrolyte resuscitation because patient is vomiting quite a lot, along with vitamins and perhaps thromboprophylaxis. So this is now the condition GTD, gestational trophoblastic disease, जो भी मैं कह रहा था हम करेंगे discuss. इसमें basically what happens, without going into too much details, is that because of the chromosomal arrangement, the zygote, basically there are multiple variants of this disease, but the general concept, if the zygote is not produced but somehow the trophoblastic tissue continues to grow, it leads to GTD, and इसको हम molar pregnancy भी कहते हैं, and there is very very heavy levels of HCG, and that basically leads actually to hyperemesis gravidarum. So no pregnancy, no zygote, but a lot of trophoblastic tissue. So this has to be terminated usually by DNC, and the patient is counseled to attempt another pregnancy. Okay. Now I think there will be a question or some case scenarios, so let's go through them. The first one is there is Mrs. M, a 32-year-old woman who presents after 6 weeks of amenorrhea. So 6 weeks of amenorrhea with abdominal pain and dizziness. Her observations on admission are blood pressure is a little down, pulse is 115, temperature is 37. Positive urinary pregnancy test. So everything goes perfectly nicely fitting with positive pregnancy. What is your differential diagnosis? What are the key points in her history, examination, and investigation? And how would you discuss the management? Now, you need to pick up a few important pointers here. So there is abdominal pain and there is dizziness and the blood pressure is low, pulse is disturbed. So what would you think? Always consider in such case ectopic pregnancy, and the way you would proceed with this patient, because the blood pressure is low and you are expecting ectopic pregnancy because of the pain. Obviously you will first manage ABC and you look for appropriate venous line and venous access, so that if transfusion is required you can do that. But then you will also proceed for investigations, right? You will do transvaginal ultrasound, for example. You must do that. ओके इन सब में से आपने ये सारे यहाँ पे लिस्ट भी उन्होंने दे दी है कि ये आपने इन्वेस्टिगेशंस करनी है, स्टार्टिंग फ्रॉम फर्स्ट ABC, फोकस ऑन सेविंग द पेशेंट, ग्रुप एंड सेव, मिसमैच ना हो ब्लड ट्रांसफ्यूजन के वक्त, तो बेसिक रिससिटेशन अप्रोच, एंड देन यू डू ट्रांसवेजिनल अल्ट्रासाउंड, एंड देन अ लॉट ऑफ इन्वेस्टिगेशन सच एज full blood count, you do HCG levels, and maybe in order to treat the patient you may think on the lines of giving methotrexate once you made the diagnosis, obviously, and then surgical procedures may be required depending upon what you decide, right? Okay, then ये केस आप लोग सॉल्व कर लीजिएगा. For each of the following below choose a single most appropriate answer from the above list. So investigation of pain in early pregnancy क्या क्या होंगे, वो सारी investigation pick कर लीजिए. Then how would you manage ectopic pregnancy, perhaps by methotrexate. So just go through this. You should be making sense out of it. The question: a 25-year-old woman present with vaginal bleed and a positive pregnancy test. So there is a bleeding and a positive test. Her transvaginal ultrasound shows a non-viable intrauterine pregnancy. So there is a pregnancy, but this is now non-viable, no fetal heart sound. So what would it be reasonable to offer her? Choose the best answer. What would you do? Now this is perhaps a miscarriage, directly laparoscopy, HCG measurement. You don't need that because this is a confirmed case of pregnancy. Methotrexate is for miscarriage, or not miscarriage, it's for ectopic pregnancy, and misoprostol is the first line that you can try there. Okay, a 43-year-old woman undergoes a surgical curettage of miscarriage. Miscarriage हुआ and now the surgical curettage, and the pathology report confirms a partial mole, trophoblastic disease. What would you do? Choose the single best answer. Start the contraceptives, prescribe methotrexate, arrange transvaginal ultrasound, HCG monitoring, and start antibiotics. So you need to learn excluding all the other options. So this is not a case of ectopic, so no methotrexate. Transvaginal ultrasound will not be necessary because you are already doing the curettage, and HCG monitoring, ये mole है तो ये already हुई भी होगी, so you don't need to do that. Antibiotics are not indicated, so contraceptives, right? Combined contraceptives. All right, so that's all about this chapter. It was a pretty simple, small chapter, and I'll see you in the next chapter very soon, which will be chapter number 6. So all the very best till I see you next.